Director of
To be talking about ventilation of the patient with obstructive lung disease. So this is intended to be interactive, which is what you're going to use your cell phone for. So I'm going to be asking questions throughout. There's not necessarily a right or wrong answer for some of these. Some answers I think are better than others, but could serve as points of discussion. There is also a lot of material, so if we only get halfway through, we'll have another in-service next Wednesday. Let's do the rest. So you can try to slow me down if you need CRCE. So here is the thing which I think most of you already did. I heard Amy beep that she got a return message. So text the message, my name, first and last name, without a space. It is not case sensitive. Send that to 22333. You should get this response, which means you're logged in. And then when you leave, after the in-service, just send the word leave, and that'll log you out. Okay, so here we go. You're called to see a patient who just arrived in the ED with COPD exacerbation. Even if you don't work in the ED, pretend you do for this. The patient's blood gases are on 2 liters per minute, pH 728, PCO2 68, PO2 55, oxygen saturation 88%. Patient complains of dyspnea, is using accessory muscles, respiratory rate is 30. Breath sounds are distant with an occasional wheeze. So what do you want to do? So these are going to be your choices. Are you going to give an albuterol treatment, high flow nasal cannula, endotracheal intubation, non-invasive ventilation, or CPAP? So now you can vote by either texting A, B, C, D, or E. And when they come in, you will see it begin to populate up here. Up, so somebody took, two people took non-invasive ventilation. See how it works? Everybody's taking non-invasive ventilation. Which is, come on in, Dennis. Which is the, all right. So everybody is, oh, we still waiting for Amy? Or no, still waiting for me? I'm sure Nancy would also do non-invasive ventilation. So, as you, I'm sure, all know, today we have abundant evidence for the use of non-invasive ventilation for COPD exacerbation. There is, with the use of non-invasive ventilation in this patient population, we avoid intubations, and it also affords a survival benefit for patients. And in fact, the accumulating evidence today suggests that for every 10 patients with COPD exacerbation who we use non-invasive ventilation for, 1 patient would survive who would otherwise die. So that's pretty powerful evidence for using non-invasive ventilation in this setting, and that's pretty much standard practice here at the MGH. I can tell you, though, that in my travels, there are still lots of places where this is kind of a foreign concept, if you could believe. So, next question. So now it's a day into non-invasive ventilation. There's breakdown and bleeding on the bridge of the nose. Of course, that never happens here, right? So now what are you going to recommend? Are you going to use a total face mask? You're going to put Duoderm on the nose, or are you going to say this is a good reason to just go ahead and intubate the patient? Okay, so how do you feel about Duoderm on the nose? You don't have to say who. Okay. So what? Why would, or if, let me put it this way. If you chose total face mask, why did you choose that rather than Duoderm on the nose?
Too late. Yeah, it's already bleeding.
I think it's too late. So already the skin's broke down, it's bleeding, and we put Duoderm over that wound and then just strap the mask back on again. It's probably not going to feel too good. So at this point, I think we're beyond the point of Duoderm. So the Duoderm probably should have been 18 hours sooner when we're noticing that there's redness on the nose and so forth. So Dennis is smiling, so I'm not quite sure what kind of a response we're getting in here.
Nothing. I need pen and paper.
So interestingly, here is a paper that was published in Respiratory Care about 6 months ago And they're looking at treatment-related risk factors for the development of skin breakdown in subjects with acute respiratory failure who get non-invasive ventilation and CPAP. So here they compared patients who got the total face mask, so the one that goes over the entire face, versus an oronasal mask, the one that goes over the nose and mouth. And the odds were 80.8, 81 times greater for getting skin breakdown with the oronasal mask than with the total face mask. So I know we have been starting to use the total face masks a lot more, and maybe we should be thinking about them even more in this kind of a patient. And then they also showed that patients who were on non-invasive ventilation essentially longer than a day, 26 hours, were like 9 times more likely to get skin breakdown. So the total face mask is a bit more expensive interface, but it's, I think we should probably be thinking about it more, and I know that we are. I know that I've seen patients out there who are now using this. So, next question. So what percentage of patients with COPD fail non-invasive ventilation? So do you think it should be 20%, 50%, 80%, or please don't tell me all of them, but actually it's working, looks like it's working pretty good.
How come it's shrinking?
Because there are more that are choosing,
Oh.
so when there are more that are
Oh,
added
I
to
was
the
looking at the
20%,
one.
yeah, it's kind
Not
of
the
it's
seven.
an optical illusion, So if you look at the studies that have been published on non-invasive ventilation for COPD exacerbation, so not like everybody we put on non-invasive ventilation, but specifically for COPD exacerbation, the failure rate is around 20%. The failure rate for everyday application, so like outside of studies, might actually be a little bit higher than that. It may not be as high as 50%, so maybe I should have put another option in there, like 30% or 40%. But the failure rate should not be more than 50%. So depending upon how sick the patient is, it could be as high as 50%. So then when do we see CF exacerbation, other kinds of obstructive lung disease? So I think generally we think about intubating the patient when the patient is fatiguing and having a rise in PCO2 despite maximal therapy. So we're doing everything we can and the patient is not turning around. And we may have the patient on non-invasive ventilation and the patient is failing non-invasive ventilation, not tolerating it well. So then when we decide to intubate, generally we choose oral intubation, which is certainly the case at the MGH. That allows us to intubate with a little bit larger tube, so there's less resistance through the tube, easier secretion clearance. I should probably also put on here better inhaled aerosol delivery. And by avoiding the nasal intubation, we avoid problems such as sinusitis, and there's an increased risk of ventilator-associated pneumonia with nasal intubations. Believe it or not, back early in my career, nasal intubations were preferable. So I can remember the day when a lot of patients were intubated nasally, which I think everybody's pretty much gotten away from that. So our goals in ventilating patients with obstructive lung disease are first and foremost to avoid air trapping, overdistension, auto-PEEP, and so forth. And as with any mechanically ventilated patient, we want to avoid overdistension injury by keeping the plateau pressure as low as possible, and certainly less than 30 centimeters of water. In patients with obstructive lung disease, how we avoid alveolar overdistension is by minimizing auto-PEEP. So if our patient has 20 of auto-PEEP, it's going to be more likely that the plateau pressure is going to be greater than 30 than it will be if we can reduce the auto-PEEP to 5 centimeters of water. We want to provide adequate oxygenation, which is not necessarily normal oxygenation, so around 90% saturation, and provide adequate ventilation. And there are different cutoffs that people would use. I would say try to have a pH greater than 7.25, but recognize that if we try to drive up the minute ventilation to improve the pH, it might make the auto peep and the dynamic hyperinflation and the plateau pressure worse. We're going to come back to that in a little bit. So as far as initial ventilator settings, whether you use pressure or volume ventilation is often per your individual bias or the bias of the unit where you work. There are issues with either approach, which we'll talk about on the next slide. Regardless of the mode, we want to avoid air trapping by typically using a relatively short inspiratory time, around a second or so. I'll show you later on in the presentation that using really short inspiratory times may not help a whole lot. Use respiratory rates a bit on the slower side than we would with ARDS, for example, 12 or 15 breaths per minute, or sometimes even lower. And targeting 6 mLs per kilogram. So we use the same tidal volumes here that we would use for ARDS and any other patient. The reason for that is that if we use larger tidal volumes, it takes more time to get that tidal volume back out of the lungs. So there's going to be a greater risk of air trapping and autopeep. Again, we want the plateau pressure as low as possible, less than 30. As far as PEEP, we may use PEEP to counterbalance autopeep. More detail about that later. But we want to be careful that if we use PEEP, it doesn't drive up the plateau pressure and make overdistension even worse. And we want to target an FiO2 again so that we have a saturation of around 90%. So any log in and help us answer the question.
I definitely have my phone on me.
You missed a couple questions already, but we're not going to back those up for you. So we want to try to maximize the expiratory time to minimize the amount of air trapping and autopeep. And I will tell you without going through the math, I can do that with you another time if you want, but we maximize the expiratory time more by lowering the respiratory rate than by playing around with the inspiratory time. So you can drop the inspiratory time from 0.8 to 0.6, and you get 0.2 of a second more expiratory time. If you drop the respiratory rate from 15 to 10, for example, you get a lot more expiratory time. So permissive hypercapnia should be part of our vocabulary when we're talking about patients with obstructive lung disease who we are ventilating. So now, what would be your choice of ventilator mode for a patient with obstructive lung disease? We could say this is a patient with severe COPD exacerbation or asthma exacerbation. So are you going to use volume control, pressure control, or pressure support? The more that come in, the person who chose pressure control is getting shrunk right out of the picture. Okay, so let's look at this. Pressure versus volume ventilation. So there are actually pros and cons of either approach. And you could argue that there is not one approach which is clearly absolutely better than the other. Although if I voted, I would have voted for volume control. And we'll see why. So if you choose volume control, if the patient gets more autopeep, more air trapping, the patient's minute ventilation will be maintained. So the patient won't get more acidotic. However, you run the risk if the patient gets more autopeep, the plateau pressure will go up, and there's greater risk of overdistension and lung injury. However, on volume ventilation, if that happens, the high pressure alarms are going to start going off on the ventilator. Now you could argue on pressure control, so with pressure control, I wasn't supposed to do that. Let me go here and back up and see a bit. All right, so that part up there in the corner, what it's supposed to say is that if we use pressure control ventilation, the problem will be if the patient gets more air trapping and autopeep, the pressure applied to the airway won't change, so it'll take away the patient's minute ventilation. However, the patient is less likely to overdistend, because the level of pressure won't change if the patient gets more auto-PEEP. So I guess that's what you sort of have to balance. However, before I put up the answer here, let's imagine that your patient is on 15 of pressure control, and we have the PEEP set on 0. What will be the patient's minute ventilation if the patient's auto-PEEP goes to 15 centimeters of water? Patient is on 15 of pressure control, 0 PEEP. Patient gets more air trapping than auto-PEEP, and the auto-PEEP goes up to 15 centimeters of water. How much ventilation will the patient get?
I'm gonna take a guess. It would be 0.
It would be 0. So therein lies the problem. So with pressure control, if the patient develops more auto-PEEP, the tidal volume, in fact, if the pressure control equals the auto-PEEP, the tidal volume will drop to 0. Because the pressure at the airway and the pressure in the alveolus would be the same. So there would be no pressure gradient for flow. So that is what I worry about when ventilating patients like this, is if they get more air trapping, they will get extremely aspirated. So let's say that we chose volume control. So here's a typical airway pressure waveform on volume control, where the PEEP is the expiratory pressure, and then we get a little bump in pressure due to the resistance through the endotracheal tube, and then the pressure goes up to the peak inspiratory pressure, and then we do an end inspiratory breath hold. The pressure drops down to the plateau pressure. The difference between the peak pressure and the plateau pressure is determined primarily by airway resistance. So if there's a big difference between PIP and plateau, it's usually not because of the flow setting on the ventilator. I don't think we can set the flow high enough so we'll have an enormous difference between the PIP and plateau. But in a patient with severe acute asthma, the PIP may be 60 or 70, right, Ernie? And the plateau might be 15 or 20. So in that patient, is that high pressure injuring the patient's lungs? So we go to the bedside, severe acute asthma, the PIPs are running in the 60s, plateau pressure is 15. We are not injuring the lungs because the lung parenchyma, the alveoli, are only being distended with a pressure of 15 centimeters of water. And then we can follow the PIP to plateau difference to evaluate the response to bronchodilators, steroids, and so forth, because what we would expect to happen over time is that this gradient would decrease. The difference between plateau pressure and PEEP is determined by compliance and tidal volume, and we think more about this in the setting of ARDS. We think about this in the setting of obstructive lung disease. So the plateau pressure is the end inspiratory alveolar pressure. That is the pressure that the lung parenchyma is actually seeing. So one day I'm sitting at home in my home office trying to be the editor of respiratory care, and I don't know if this is Ernie or one of the fellows in the MICU sends me a text, and this is it. So this is a patient with severe, I want to say, acute asthma, intubated in the MICU, ventilated pressure 76 centimeters of water, plateau pressure only 21. So this patient, I would argue, is not at risk for ventilator-induced lung injury with this plateau pressure. This, the question that came along with the text is this the highest airways resistance you ever saw? And my text response was, yes. So for you or me, do you remember what is the normal airways resistance? So you go down to Cox 2 to the pulmonary functional laboratory and you get into body box and you pant against the shutter like you learned about in school. What's the normal airways resistance? It's like 1 or 2. So this patient is not ready for a spontaneous breathing trial. That's sad. I think we're going to defer the SPT there. So how do we calculate airways resistance then? So the airways resistance, the inspiratory airways resistance is the PIP minus the plateau divided by the flow. We have to do that on constant flow ventilation, so we cannot do it on pressure control. We cannot do it on a descending ramp of flow. So we have to change the ventilator to square wave to constant flow. And then it makes the math easier if we set the flow at either 30 liters per minute or 60 liters per minute. Because the units are centimeters of water per liter per second. So if you set the flow, if you can set the flow at 60, then the denominator is 1, and the airway's resistance is pit minus plateau. Makes the math much easier. Now that may result in a very short inspiratory time, so then you could choose a flow of like 30. So in intubated patients, I don't like to see that being more than 10. For you or me, it's like 1 or 2. So why might the airway's resistance be increased? Well, maybe there's secretions in the airway, so think about severe acute CS, bronchospasm, asthma, COPD, small endotracheal tube, patient who got intubated in the field, an adult patient with a 5 or 6 ET tube because it was a difficult intubation. And airways resistance will be increased with a low lung volume, something I've heard referred to as obstruction. So it looks like obstruction due to a restrictive low lung volume. So with ARDS, for example, not only do we wipe out a lot of alveoli, that's what you see on the chest x-ray, but you wipe out the airways that go to those alveoli. So that results in some increase in airways resistance in patients with ARDS. That is also, though, important to recognize that the increase in airways resistance that you may measure with ARDS is not bronchodilator responsive. So we shouldn't put those patients on albuterol and Atrovent. And in fact, there's at least one study that shows that using albuterol and ARDS worsens outcome. So resistance may be increased with ARDS, but not an indication for bronchodilator. And then it's also important to remember, so this gets back to sort of basic respiratory physiology, that expiratory resistance, so here we're looking at resistance as a function of lung volume, expiratory resistance is greater than inspiratory resistance. Patients with ARDS who have a low lung volume have a higher airways resistance, as I just said. Expiratory resistance is higher than inspiratory resistance because during the inspiratory phase, the pressure in the airway causes mechanical bronchodilation. And then during exhalation, the airway gets smaller in diameter, which increases resistance. So I point that out because sometimes we measure airways resistance on a patient with COPD, and it's 20, which is elevated for sure, but the expiratory resistance might be 40 or 50. And I'm not going to get into in this lecture how we can calculate expiratory resistance. There are ways that we can do it in patients with obstructive lung disease. It can be twice or more what we measure in our usual way of doing pips and plateaus. Sometimes we're fooled because this patient with COPD, they measure the resistance and it's not so bad, but every indication is they have a lot of resistance and that's what that is. Okay, so just as we can do an end inspiratory pause to measure the alveolar pressure at the end of inspiration, what we call the plateau pressure, we can do an end expiratory pause, as you all know, to measure auto peak. And when we put our finger on the button and it closes all of the valves at the end of inspiration, normally what should happen is that the pressure should stay right at the level of the set peak. If the pressure bounces up to some higher level than that, by convention, we call that auto peak. The difference between the end expiratory alveolar pressure and the peak set on the ventilator. So this pressure is the pressure that the alveolus is seeing at end exhalation. Now, in order to make that measurement, the patient cannot be having any active breathing efforts. So as you know, you can't make the measurement on pressure support. It won't even let you because even if it did let you, the number wouldn't mean anything because the patient's trying to take a breath and the pressure's going all over the place. Plus, it also treats the lungs as though the lungs were only one airway and one alveolus. More on that in a minute. So here is another text message I get one day from somebody in the NICU. I don't remember who. Could have been Ernie, because Ernie sends me pictures like this from time to time. And the question was, is this the highest auto peak that you ever saw? 34 centimeters of water. That's pretty high. And then I responded, what's the plateau pressure? And as I recall, the response that I got was 28. So now, can you have more auto peak than plateau pressure? Can you have more expiratory pressure than inspiratory pressure? I don't think so. And do you notice anything about this auto peak measurement that might cause you to have pause about the measurement? Anything about that that might look a little bit out of the ordinary? So look at how I drew it here. Previous. So look at how I drew it here. Does this look like that? So notice that this goes up very slowly, but then even here, the pressure is still going up, right? We're never getting any plateau there. So how could it be that you do an auto peak measurement and there's no plateau on the airway pressure waveform? What could be causing the pressure to be going up during exhalation? Ernie knows, but So imagine that you blocked off the airway and the patient is going, blowing out, pushing out. What's that going to do to the pressure that the ventilator measures? Keep going up like this. So I remember, I forget who the fellow was, Ernie, but I remember I said, well, I think that's active exhalation. And he said, there's no way. But then the patient needs to get bronch. So what do we do when we bronch somebody? We go on a ventilator, we give them a lot of sedation. And here's the same patient right before the patient got bronch. This is exactly the same patient like an hour later. So now, notice now that we do see a plateau there. So the patient doesn't have an auto peak, but whatever that was on that last slide, 31 or whatever, patient's auto peak is 11. I mean, it's still nothing to sneeze at. I mean, it still is of concern, but it's not 30. So something we need to keep in mind. Here's the other thing we need to keep in mind. So since Lindsay sat here, I'll pick up Lindsay. So the patient gets intubated, severe acute asthma, and Lindsay's on the ball, so she measures the plateau pressure, and it's 5. So she tells the team, plateau pressure is 5. And they say, don't believe it. This patient is hemodynamically unstable. We think that's because they have a lot of auto peak. We look at the chest x-ray, the diaphragms are pushed way down here. The patient looks really hyperinflated. There's no way the auto peak is just 5. So Lindsay says, well, okay. So she goes back in and measures it again. And it's 5. So then Lindsay calls Carolyn, who's still in charge, and they both go in and they measure it, and it is 5. How might that be? Here's how it might be. So remember that what I said before is during inspiration, airways get larger in diameter, and then during exhalation, they get smaller in diameter. And let's say there's a lot of resistance, a lot of bronchospasm in this airway. So that this airway during exhalation collapses when the pressure in the alveolus is 20. So how much auto peak is in this alveolus? 20. And this one there's 15. And this one there's 13. But when you do your breath hold maneuver, do you measure this 20? It's impossible if this airway is closed. You can't measure the pressure past the occluded airway. So the only thing that you get is the auto peak through this airway that has not completely collapsed during exhalation. So we can be fooled. And this is most likely to occur with severe acute asthma, where even with a good measurement, we may be underestimating the level of auto peak because of airway closure during exhalation.
Would our graphics still show that they're fully coming back to baseline?
Yeah. Oh,
On the ventilator?
No, it would not. So the expiratory flow would not come back to baseline because there'd still be flow coming out of this airway.
So that's one of the times when you go more by graphics?
Or just and by clinical presentation. So the patient is hemodynamically unstable, they're hyperinflated on their chest film, their plateau pressure is 40 on a tidal volume of 200. I mean, you just have to go by other indicators. And I don't know of any way that you can get around this. There's no way that you can measure the pressure upstream in this alveolus.
So when would you suspect it? If you,
So a patient, severe acute asthma, could be COPD as well, or severe acute asthma, who is very hyperinflated on their chest film, and they're having complications as a result of that hyperinflation, like they're hemodynamically unstable because of the high intrathoracic pressure. So, things aren't always as they first appear.
Would there ever be an instance that, say, the airway where the RP is 5, that closes but an airway at higher pressure is open?
It is unlikely because in the thorax, the pressures, the pleural pressures are greater in the more dependent part of the lung, so the airways tend to collapse more at the bottom of the lung. So in ARDS, we think about alveoli collapsing more at the bottom of the lung. Here, airways collapse more at the bottom of the lung. So it would be unlikely that this would be sort of upside down, because these alveoli, these airways, I should say, are exposed to a higher pleural pressure, which would tend to cause them to collapse.
So the chances are that we'll underestimate.
Absolutely, yes. So, and sometimes I think it can be substantial. Ernie?
Yeah.
Oh, I thought you were going to say
No.
something. We were just going to stretch the back of your head.
so it's,
It makes you look very studious when you do that. So, autopeep. So more discussion about autopeep. So the reason why we care about autopeep is not so much because of the autopeep per se, but because it causes air trapping. It's the result of air trapping, I should say. So autopeep is the result of air trapping, and it causes dynamic hyperinflation. So in other words, it causes the lungs to be hyperinflated, which increases the intrathoracic pressure, which causes hemodynamic compromise. So how does our patient get autopeep? Well, it could be because of how we set the ventilator. So higher minute ventilations are likely to cause higher degrees of autopeep. And that relates to both the tidal volume and the expiratory time. So if we put in a big tidal volume, it's going to take more time to get that tidal volume back out of the lungs, so there's a greater risk of air trapping and autopeep. Or if the inspiratory time is too long relative to the expiratory time, greater risk of air trapping and autopeep. And again, as I put on the slide, the expiratory time is determined by the inspiratory time, I/E ratio, and respiratory rate. And the respiratory rate has a greater effect on air trapping than the I/E ratio per se. So then if we want to reduce autopeep, we should think about ways of reducing the minute ventilation, allowing permissive hypercapnia, which means that we have to reduce both the tidal volume and the respiratory rate. So sometimes what I see done is a patient has autopeep and the respiratory rate is decreased to allow more expiratory time, but then the tidal volume is increased to keep the same minute ventilation, and usually if you do that, you're right back to where you started. Because what you gain on the decreased respiratory rate, you lose with a higher tidal volume. And then autopeep is also determined by lung function, resistance, and compliance. So with high airways resistance, COPD or asthma, there's a greater risk of air trapping and autopeep. Also, if you have a higher compliance, that increases the risk of air trapping. So patients with COPD are at greater risk for air trapping and autopeep because they have alveolar destruction, which means that they have a higher lung compliance, so there's less elastic recoil pressure pushing gas back out of the lungs. So the reason we care about autopeep is it drives up the plateau pressure, causes lung injury, increases the work of breathing if the patient is not intubated. You can try that yourself, so you can breathe into like total lung capacity, which would be like dynamic hyperinflation, and try to breathe. Not very easy. Causes hemodynamic effects because of the high intrathoracic pressure, can cause pneumothorax, can cause difficulty triggering the ventilator, which we'll come back to in a minute. So then how do we fix this? Well, we correct this by reducing the minute ventilation, so for allowing for permissive hypercapnia and treating the lung function with bronchodilators, steroids, and so forth. Interestingly enough, permissive hypercapnia was first described in the literature in the setting of severe acute asthma. You usually think about it in the setting of ARDS, but it was first described in the setting of asthma. So then this illustrates the issue with triggering related to autopeak. So this is a patient with COPD. I think this patient was in the RACU like about 10 years ago when I took these graphics. So here we're looking at flow, inspiratory and expiratory flow, airway pressure, and in this patient I placed an esophageal balloon catheter. So when the patient makes an inspiratory effort, that drops the pleural pressure, which drops the esophageal pressure. So here the patient makes an effort, does not trigger a breath. Here's an effort, does not trigger a breath. Here's an effort, does not trigger a breath. So when we see that, that is like a classic sign of autopeak. So did we need to put in an esophageal balloon to figure this out? This actually makes for a great slide for the teaching point. But do we need to put in esophageal balloons to figure out that the patient has autopeak that is getting in the way of the patient triggering? How would you figure this out without the esophageal balloon? Actually, several things on here that help you to figure it out.
Put your hand on the patient's diaphragm.
Or just on the patient's chest. And so you can look at the patient, feel the patient's chest, and listen to the ventilator without even looking at the graphics. And if the patient is making efforts in the ventilator, you don't hear the ventilator deliver a breath, that would suggest that this is happening. So we could break down and look at the patient and listen to the ventilator. So the patient's making efforts that don't trigger. How else could we figure this out? What do you see on the flow waveform every time that the patient makes an effort that does not trigger?
Maybe where those little arrows are?
Right, where those little arrows are. So you see this notching on the expiratory flow waveform? So when you see that expiratory flow notching, that is characteristic for a patient who's making an inspiratory effort insufficient to overcome the autopeak to trigger the ventilator. And then the other thing you can see is here the flow. At end exhalation, the flow is not coming anywhere close to zero, suggesting that there's autopeak. So the esophageal pressure measurements make it obvious, but I would argue, I would agree with Bonnie that we should be able to figure this out just on our exam of the patient. Just by looking at the patient's breathing 30 breaths per minute. You look at the rate on the ventilator, and the ventilator's giving 18 breaths per minute. So there's a mismatch between the breaths that the patient's taking and the breaths that the ventilator's giving. So what do you want to do about it? So this is a problem. To me, I cannot imagine anything more anxiety-provoking than to be on the ventilator, breathe in, and get nothing. So little wonder that this patient's going to be asynchronous, anxious. So what are we going to do about it?
Call me.
No, maybe a day that I'm not here. So what are you going to do about it, Ernie?
Go up on a peak, presume that the respiratory flow is not sufficient to overcome the autopeak. So try to go up on the peak.
So we could try to go up on the peak to counterbalance the autopeak to make triggering better. But in the long run, you're going to have to fix the autopeak, right? Bronchodilators, clear secretions, and so forth. So what I'm going to segue into now is how we could go up on the peak to try to make this better. So let's step through this with this cartoon. So here we have a patient. We're going to assume that the peak on the ventilator is set at 0. and the trigger sensitivity is set at -1 centimeter of water. There is no auto PEEP, so at the end of exhalation, the alveolar pressure is 0. So in this case, the patient breathes in when the pleural pressure drops by 1 centimeter of water, the alveolar pressure drops by 1, the proximal airway pressure drops by 1, and the ventilator delivers breath. Okay? So now the patient develops 10 centimeters of water of auto PEEP. So now we put some resistance here in the airway. So at end exhalation, the ventilator is still set on a PEEP of 0. The end expiratory alveolar pressure is 10. The patient now has to generate an effort of 11 centimeters of water. Enough effort to overcome the auto PEEP, because until the patient breathes in at least -10 centimeters of water, there will be no change in pressure at the proximal airway. So in this patient, let's say the patient generates an effort of 5 centimeters of water. What will the ventilator do? Nothing. So the ventilator, it'll be a mistrigger. So what if we change the trigger from pressure trigger to flow trigger? Is that going to help?
No.
Nope. Because not only will we get no pressure change in the proximal airway till we overcome the auto PEEP, we will also get no flow change in the proximal airway. So it won't make any difference whether it's pressure triggered or flow triggered. So now Ernie wants to add in PEEP, so let's do that. So now here is our patient with 10 centimeters of auto PEEP, trigger sensitivity of -1. So at end exhalation, somehow my resistances are showing up here, that's okay. So then at end exhalation, there's still flow coming out of the airway. So if the pressure here is 0 and the pressure here is 10, there's expiratory flow. And if we have a lot of resistance in the airway, theoretically, if we raise up the pressure downstream, so the pressure here is 10, we raise the pressure downstream at the proximal airway, in this case up to 8 centimeters of water, it will not affect the upstream driving pressure, provided there's a lot of resistance here and it's flow limited, as we'll get to in a minute. But now what happens, when we raise the PEEP up to 8, the pressure only needs to go from 8 to 7 to trigger. So now the inspiratory effort is only 3 centimeters of water. So we use PEEP to counterbalance auto PEEP because the ventilator triggers relative to the set PEEP, not due to the auto PEEP. The ventilator doesn't know what the auto PEEP is. So this typically only works. So using PEEP to counterbalance auto PEEP is only effective in the context of flow limitation. So it tends to work very well in COPD. Doesn't work as well for asthma. Sometimes it works for asthma, sometimes it does not. Now, how much PEEP are you going to add to counterbalance the auto PEEP? So you have your patient here. So how much additional PEEP are you going to use to counterbalance the auto PEEP? Put it on 3, 6, 12, 15. So what you do is you increase the PEEP until there are no missed triggers. So it's a trial and error. So the patient's not triggered, so keep going up on the PEEP so the patient can trigger. If you go up on the PEEP to 12 and now the patient's perfectly in synchrony with the ventilator, you can conclude that the patient probably has an auto PEEP of about 12 or 15, something like that. Or if you put the patient on volume control, you can increase the PEEP until the plateau pressure and the PIP start to increase. Because as long as the PEEP is just counterbalancing the auto PEEP, the plateau pressure will not go up and the PIP and the plateau will not go up. So let's say you go through this exercise and you end up on a PEEP of 8, but the alveolar pressure is still 10, what you started at. If somebody says to you, oh my God, patient's going to drop their blood pressure. Going up in the PEEP, I'm concerned the patient's going to drop their blood pressure. What are you going to say? Alveolar pressure hasn't changed. So the intrathoracic pressure hasn't changed. It should not affect the patient's blood pressure. Now this is from a paper that's pretty old now, almost 15 years old. but illustrates here a patient with COPD and here a patient with asthma. When the PEEP is raised from 0 to 8 in the patient with COPD, the end expiratory lung volume doesn't change, the airway pressure doesn't change, PIP and plateau doesn't change, and the baseline esophageal pressure doesn't change. So raising the PEEP in this patient with COPD does not contribute to more dynamic hyperinflation. Whereas in this patient with asthma, when the PEEP goes from 0 to 8, the end expiratory lung volume goes up, the PIP and plateau go up, and the esophageal pressure goes up, suggesting that here the PEEP is causing more dynamic hyperinflation and potentially causing more problems. And the reason for that is that patients with COPD tend to be flow limited. So that means that no matter how hard they push, they don't get any more flow out of their airways. Whereas patients with asthma tend not to be flow limited. So, do this and then we'll ask the next question. This is a paper published, 10 years ago now, which looked at a series of patients with asthma. And they showed that in some patients with asthma, when they increased the PEEP, the lung volume went down. So the PEEP was actually very helpful here. In some patients with asthma, when they added PEEP, initially the lung volume did not change until they got to higher levels of PEEP. And then they found that there were other patients with asthma, when they added PEEP, right away the lung volume started to go up, making things worse. My take-home message from this slide is that in an individual, so in patients with COPD, PEEP will often counterbalance on a PEEP. In asthma, it may or may not. And the only way we know is to try. So we just sort of have to do an N of 1 experiment in an individual patient. So, now, time to get your phones out again. So how would you know in an individual patient if the patient is flow limited? So, try on air, educated guess, ask the doctor, please nobody take that, or press on the patient's belly. But when I've done this lecture outside of here, you'd be surprised at how many people pick that. Okay, so we had a little bit of attrition. So what would be the educated guess? Well, the educated guess might be that you know the patient has COPD and they don't have asthma. So that's not unreasonable. Trial and error might mean that you turn up the PEEP and you see if it's easier for the patient to trigger or if the patient's plateau pressure goes up. Right? So that's trial and error. It's not unreasonable. Or you can press on the belly. Because if you press on the belly and there's no more flow that comes out of the lungs, that is the definition of flow limitation. So the flow is limited so that irregardless of how hard you push, you don't get any more flow. So here's an example. So this was originally a screenshot off of the ventilator, but I had somebody redraw it, which they did a really nice job redrawing this so I could publish it in a paper. But here is a patient up in the MICU with severe COPD, and on the first, second, third, fourth, on the fifth breath, the pulmonary fellow pushes on the belly. And he really pushed harder than I probably would have pushed. But notice, even though he was pushing hard, so the abdominal pressure goes up, the thoracic pressure goes up, but there's no more flow that comes out of the lungs. The expiratory flow is the same as it is here or here. So why is that? Pushing on the belly raises the intrathoracic pressure, but that pressure squeezes down on the airways as much as it squeezes down on the alveolus. So the alveolar driving pressure goes up, but the airways resistance goes up, and the flow doesn't change. So some of you who have hung out with Bob Brown in Iraq, you know this is one of his favorite tricks that he'll do to demonstrate flow limitation. Okay, another case. Right as you're about to fall asleep, I'm going to make you pay attention again.
Can you finish your question?
Yeah,
What do you do about flow limitation?
so that's actually a good question. So what that would mean is that if the patient's flow limited, you would be more likely to be able to raise the peak to counterbalance auto peak without contributing to more dynamic hyperinflation. So that would be the patient then. So if the patient's not flow limited, which is often the case with severe acute asthma, might set the peak on 0. If the patient is flow limited, like severe acute COPD, then I would think about using peak to counterbalance the auto peak. So that's actually a good question. That segues into this next discussion, which has to do with why we often set the peak on 0 with patients with severe acute asthma. So this is a 41-year-old female, comes to the MICU following a PEA arrest secondary to presumed asthma exacerbation. She uses albuterol, but not a controller. And besides that, it was not even clear whether there was any albuterol in her MDI canister. May not have been. She gets intubated in her home by paramedics, gets transported to the ED, and then comes up to the MICU. pH 7.02, PCO2 92, PO2 236. Ventilator settings are tidal volume of a ½ liter, a rate of 26, PEEP is 15, 100% oxygen. Total PEEP is 22, plateau pressure is 32. And she's already on continuous albuterol, 15 milligrams per hour. So you got the picture? So what are you going to do? Oh, that's dynamic hyperinflation. See how hyperinflated her lungs are? So we can count ribs. I can count at least 11, if not 12 ribs there. So she's very hyperinflated. But other than that, there's no infiltrates and so forth in her lungs. Heart size is normal, so she's not in failure. So, we're going to decrease the FiO2 because her PO2 is so high. Well, what else are you going to do? So are you going to decrease the rate and increase the tidal volume to keep the minute ventilation constant? Are you going to decrease the rate and decrease the tidal volume? Are you going to switch to pressure control? Or are you going to add heliox? What do you want to do? So there are your choices again. Wow, I'm liking this group. So what some people would do is they say, well, let's decrease the rate so we can have more expiratory time, but let's increase the tidal volume so we don't lose minute ventilation. But we already talked about that. That's not going to help anything. And we talked about the problems with pressure control. If you choose heliox, I would not have an argument with that. But as I'll show a little bit later, maybe it'll be next week, the heliox has fallen a little bit out of favor in recent years. The more recent studies have not been as encouraging of heliox. So let's look at what happened to the patient. So I'm going to show you why you chose the right answer. So what we did was we decreased the rate from 26 to 20, and we did not change the tidal volume. So we reduced the minute ventilation. We dropped the peak from 15 to 5. And when we did that, the plateau, we dropped the FiO2 to 0.6. When we did that, the total peak went from 22 to 12, and the plateau pressure dropped from 32 to 22. Her repeat blood gases were that her PCO2 came down despite that we dropped her minute ventilation. And we then were really feeling emboldened at that point, and we dropped her peak to 0 and her respiratory rate to 18, and her pH came back 7.11, PCO2 of 56, PO2 of 151. So we're going down on the ventilator settings, and she's getting better. Kind of paradoxical, right? Going way down on the minute ventilation, our PCO2 is dropping. So how do you explain this? So did they sneak in and paralyze her when we weren't looking? She eventually did get paralyzed, but after this. So the lower auto peak results in less dead space. The bronchodilators and the steroids are finally kicking in, or there's a big mucus plug that comes out. What do you think? You all think just like me. So it could have been if the patient was paralyzed, and she eventually did get paralyzed, but it was after we made these changes. And it could be because the bronchodilators and the steroids are kicking in, but it's a little soon for that. There was not a mucus plug, and so B is what happened. So let's explain how that can happen, and then we will stop. So a little bit of physiology. So we need to go back to school here. Sorry. So we know that the arterial PCO2 is determined by how much CO2 your tissues are making and alveolar ventilation. So it's really the alveolar ventilation which determines the PCO2 rather than the minute ventilation per se. And the minute ventilation, what we said on the ventilator, is determined by dead space ventilation and alveolar ventilation. Ring a bell from way back when? So now let's imagine that we are ventilating the heck out of our patient, and the patient in this case has 10 centimeters of water of auto peak. So that causes alveolar overdistension. And with alveolar overdistension, that collapses the blood vessels going past this alveolus. So now we have ventilation with less blood flow or without blood flow. And what do we call ventilation without blood flow? Dead space. So if we have a lot of dead space for the same minute ventilation, it's going to drop the alveolar ventilation, raise the PCO2. So now let's say we turn down the minute ventilation. When we turn down the minute ventilation, the auto peak goes from 10 to 5. Now we have better blood flow going past this alveolus. So with the lower minute ventilation, there's lower dead space. So that what can happen is, even though we drop down the minute ventilation, the dead space ventilation went down more than the minute ventilation, so the alveolar ventilation went up and the PCO2 went down. And if Ernie had $10 for every time that we've seen in the MICU, somebody whose minute ventilation is going up, 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 trying to chase after their PCO2, and their PCO2 is going up, 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 up. And then Ernie comes along and says, I wonder what will happen if we just drop the minute ventilation. And we see this happen. But it's an easy trap to fall into. I get it. Your patient has a PCO2 of 90, your knee-jerk response is you're going to turn off the minute ventilation. But if this happens, it can just make it worse. Yeah, we have seen, I'd say we've seen this here a number of times in the MICU. We get down in the minute ventilation of PCO2.
It's a lot more like last month.
Yeah, because we've had a lot more like asthma up there.
It's okay the last month.
Okay, you've given me an hour of your attention, and you've humored me with your responses on your cell phone. So we could actually continue this next Tuesday, or next Wednesday, I should say. I'm very sure I don't have an assignment next Wednesday, so we can. That's my embarrassment for today. I didn't know I was on the schedule until I got here this morning. So, but at any rate, it all worked out, and so next Wednesday, yeah. So if you want, we'll just continue this. We can back up a few slides for people who are not here today. Okay, that's it for this time.
Thank you.
So I didn't make. That's reaching the limits of what we would accept for lung injury. Now, even worse.